All right, everyone. I just want to say hello and I want to welcome everyone to the university's Let's Talk COVID town hall meeting. My name is Alex Bako and I am the university's director of the Office of Risk Management. And I also serve as the chair of the university's executive COVID-19 committee. Um, at the beginning of the fall 2021 this semester, the university decided to hold these town hall meetings on a biweekly basis as a means to inform the Firebird community of the administrative and operational policies and procedures related to the pandemic. In our last town hall, we asked several cabinet members and senior administrative leaders to provide unit updates regarding academics, facilities, human resources, and student development services. This week, we are fortunate to have with us the lead epidemiologist from the District Department of Health to talk to us about COVID-19 public health metrics in the district, how we're doing here at UDC, and possibly future forecasts on where we might be headed with the pandemic. Before introducing Dr. Mangla, I wanted to share a couple of pieces of relevant information. First, uh, good news, we have had no new cases of COVID-19 on campus among students, staff, and faculty since our last town hall meeting 2 weeks ago. So that's a good sign that we might be doing some things right to protect our community and prevent the spread of COVID-19. The second item I want to share is that the district recently rolled out a testing program called Test Yourself DC. I would hold up the kit, but I think it's blurred. I think my background is blurred. But it's a free at-home self-test kit for COVID-19. It's something that can be self-administered to yourself or to someone in your family at home. You can drop the kits off at any one of, I think, 10 or 12 locations across the district. And again, you'll get results back within a couple of days. And so while we do have testing here on campus for people who may be symptomatic or people who are on a weekly test schedule, this is just another tool that we have at our disposal to help protect our community. If you have any questions about the Test Yourself DC program, please raise them after our guest presentation in the question and answer session. So with that said, our guest speaker today, Dr. Anil Mangla, is a former professor of public health. He's a former director of a school of public health, and he's served as the state epidemiologist in the state of Georgia, and I believe another state. I'm sorry, Dr. Mangla, didn't get the complete bio for you.
Oh,
Currently,
it's
go ahead.
Indiana.
Indiana, right. Currently, you are the state epidemiologist for the District Department of Health. In this role, you provide guidance and expertise on epidemiology and infectious diseases to the district, including the District of Columbia, OSSI, the Department of Corrections, all DC public schools, the state superintendent, and all colleges and universities, as far as I'm aware. So on behalf of the community we like to call Firebird Nation, I want to welcome you to spending your time with us today and thank you. You have the floor, Dr. Mangla.
Thank you very much, Alex, and thank you very much to the Vice President as well for giving me this opportunity to kind of present to you guys. Alex and I go back, I think, over a year since the pandemic had started. I joined DC Health maybe about 15 months ago, and we met at the consortium meetings. And kind of ever since kind of kept in touch and briefed one another every few weeks. So I'm very familiar with the university, their numbers, and I thought, let me do this presentation for you guys. It's a very big picture. I think it's going to be good for question and answers. I think that's where we want, but also to give you an idea of what COVID is, how the vaccines are made, vaccine hesitancy, vaccine myths, and then where we're going. So kind of really comprehensive, right? I could go into more details with each of those topics, but due to time, I'm not going to do that. So I'm going to share my screen, and I have a really strong, robust PowerPoint presentation with the details that we want to kind of share with you today. So let me know as soon as you see my screen, we will get started.
We can see it.
Perfect. So as Alex has introduced me, I'm not going to go into that, but I serve as the state epi and the bureau chief for epidemiology for DC. And, every outbreak or infectious disease comes through my office. So very familiar with this. I've had over 15 years of experience in this capacity. So kind of pretty familiar with any of the outbreaks that occur. There's a lot of things I want to cover. It's going to be quick, but I think it gives you a really big picture, and that's what we're all about, right? So a little just kind of reviewing about COVID, some of the rates of vaccines and rates here in DC, give you some of the benefits of getting the vaccine if you have not yet got it. Some of the myths that you may hear on social media, with friends, people that are concerned, people that are on the border of taking the vaccine. And then some other sources of information that you could kind of reach and have to educate you or get you more information. And then kind of open the space up for questions if you have any hesitation or anything you're unsure of. I'm here to kind of answer those and I normally make sure that anything I answer is fact-based and best practices. So there's no deviation of, any myths or any conspiracy theories. So I want to applaud you guys just before I even start, right? So this is really specific of what Alex had brought up. I mean, a 90% vaccinated rate in the employees is just, we don't see much of that. And if you have heard about herd immunity, in this case, we're not going to talk about herd immunity, but, you're reaching these points of herd immunity, right? So it's just an incredible number. But even more important is student population, right? 99%. I don't think I have seen that number anywhere here in DC. So a phenomenal job. And I got to thank the president, vice president, the cabinet, and then also the key person in preparedness is Alex with all his enthusiasm, making sure people are safe. And without him, I don't think this could happen. So congratulations, Alex. And then, of course, as he was mentioning, the number of infections you guys have had, very, very few. And again, you are not seeing any positives, which is, that's a success story right there, because when we're looking at our numbers right now, we're going down in the fourth kind of wave, but it's high, and I will share that with you guys. And there we are. So as you can see, this was the first wave, second wave. We're just over a fourth wave. We're going down. I don't want to get too excited with this because, as you know, this virus has changed all the time. There's two reasons I don't want to get excited. We're coming into Thanksgiving, Christmas. That was around this time, remember? See where we were last year? And then what happened? And look where we exactly last year, but look where we this year. We're way ahead, right? So when these holidays come, when travel comes, normally things go up. So I'm hopeful it goes down, but we got to err on the side of caution. I like this slide because this slide kind of shows you this was the vaccinations during that same period, right? When this started going down. So the vaccination rates went so high around this, between March and April. And as those vaccination rates went up, as you can see, case rates went down. I'm not going to say they proportional to one another, right? It's not like a coincidence, but it also kind of clearly mirrors as the vaccinations went up, our case rate went down. Okay, so how it spreads. A lot of you guys know this already, but I think it's good to talk about it. So just to give people an idea. So how does it spread, right? We all know how this virus spreads. And the spread is very clear. It spreads through your droplets. So when you're talking, when you're sneezing, that is very clear. Breathing, something splashes. If you touch it, you touch your eyes, you touch your mouth. That's kind of the key. The fundamental thing here is these droplets. The virus is in the droplets, so it can spread. This is a really important slide, right? Because this is to do with masks. Now, as you already know, if there's no mask, there's a high risk of spreading from one person to another. If one person wears a mask, that spread is still going to occur, but he's going to be more safer. As the person who actually has a mask, who is talking, as you can see, the spread is much less because of the vapor, right? But if both wear masks, again, it's not 100%, but it is much lower risk. That's why these masks are a layered mitigation process when they're so important. This is also that 6 feet. Everybody asks why 6 feet. The key fundamental part of 6 feet is normally these droplets are about 5 to 20 micrometers in diameter. Any of these things that are that size where the COVID is will fall within that 6 feet and less. So if your distance is a little more than 6 feet, you're relatively safe because the droplet's going to already be on the ground before it gets to you. Again, basic science, importance, you can be safe if you just follow these guidances. This is a great slide because it's showing you the original alpha. Now remember, before alpha, we had the Wuhan strain. So the Wuhan strain changed to the alpha, which was much more contagious. And then came the delta, which is even more. So as you can see, the alpha, every one person could have infect 2 people. Look at what's happening with delta, right? With delta, you actually get in 1 to 5. What does this actually tell you? So if you hear the news quite often, it's called the R0 or the R naught value. And the R0 or R naught value is also called the transmission number, right? And it's just telling you how many people could be infected by one infected person. I'm not going to go into details here, right? This is normally people will talk of what a mutation is, what a variant is, what a strain is. So mutation, any of you guys that are in biology, a mutation is something in your DNA that just one of these nucleotides changes. So it's a mutation. A variant is when there is an accumulation of these mutations within the virus that causes this variant. So as you can see, there's many variants, right? And then the third thing, when it becomes a strain, actually when you can prove it's a strain, when that variant has now completely new biological capacities, right? So that's when it goes a strain. So that's kind of giving you that, difference when you hear those words. So let's talk about vaccines, right? So do you want to get vaccine or do you want to get serious illness? So here's someone getting a vaccine, 1, 2, 3, it's over. You don't get a vaccine, you most probably will end up on a ventilator, right? I guarantee you, if anybody is going towards medical school or nursing, if you've seen anybody, it is not fun. To avoid this, it is serious illness, hospitalization, death. If you want to avoid that, and I have data showing that, get vaccinated. Why you don't want to get COVID? Again, it is very clear, right? You don't want to get COVID because of hospitalization, and then also these long-term effects that you could get because of COVID. And so, there's a lot to read about that, but I just want to kind of be very clear that the amount of diseases that you could actually get is much more. Can someone have on silence, please? Then I want to talk about what actually this COVID vaccine is all about, right? So everybody says, oh, even if I get vaccinated, I'm going to get positive. Absolutely. I'm not going to deny that. And I'm going to get more into that type of slides. But what the vaccine does do, and this is clearly evidential of that, is 98.9% of individuals that were not fully vaccinated were now becoming cases. 98.6 individuals that were not vaccinated have been hospitalized. This is national data. I also have local data that's going to kind of help you. And 98.7% of individuals that were not vaccinated actually have died. So this is a very clear indication of vaccinations do work. So with that said, let's go to the type of vaccination. So everybody knows there's 3 different vaccines that are available. You're going to get the Pfizer, Moderna, and the Johnson & Johnson. They all work. 2 of them are 2 doses. The one is 1 dose. When you regard it as fully vaccinated 2 weeks after your final dose. Okay. So how do these vaccines work? And I think this is where I want to kind of make it clear, because many people have said, if I get my vaccination, it's going to alter my DNA. If I get vaccinated, I'm going to get sick. None of that. These are the new technology modified vaccines that are not live vaccines. So I'm going to give you a really good idea on this. So these are now new technology. We do not use live vaccines or attenuated vaccines in this, right? It's called the RNA vaccine because what happens is the RNA is injected into an individual. This RNA is very specific. So the role of an RNA is actually to make a protein. And so these coronaviruses, or if we call in this, the COVID, they have these spikes. These spikes attach to your membranes or your cell. And these spikes are called, it's a spike protein. So what this RNA does, it manufactures these spike proteins and it mimics the actual protein. So I'll go into more detail in that, but what we want to kind of go through here is something like this. So this is a great slide, and I'm going kind of real quick. So anytime you get infected, your body starts developing these B cells that fight an infection. And so you develop these antibodies, and these antibodies are these Y-shaped kind of molecules, right? They attach to the antigen that is like the foreign particle, foreign body virus, and deactivate it, just like that. Then it kind of subsides, your antibodies subside, but they stay in your memory cell all the time. So when you get infected again, this is the same like why you get vaccinated for chickenpox, same thing, right? You have that antibodies. So the next time that same virus or particle comes into your system, your memory cells already recognize this particle. So say, for instance, we're talking of COVID. And so think of it this way. You started here initially, your body already has some, so it starts activating really quick and starts working on that virus. Your antibodies go much higher. See that the second time? And then they taper off, and then you have that threshold. So your body always has that antibodies within you as a threshold that will keep you, relatively immune to that particle in future. But look what happens the second time you get infected. For the first time to reach optimum, it took 7 days, and it was about a certain level. So this is what happens when you get vaccinated. When you really get sick, look what happens. Your max occurs on day 3. So your body is already starting to fight it way earlier, and you have many, many more antibodies. That's why it hits that virus so fast. You don't have to get hospitalized, and death is almost, very, very rare because you have that built antibodies within your system. So having said that, let's talk of this mRNA. So the mRNA, every mRNA in your system actually gets translated into a protein. So the spike is a spike protein, right? Let's take, for example, insulin. Insulin is a protein in your body. So you have a specific mRNA for insulin. That insulin gets transcribed, and transcription is a process in your body that converts mRNA through your ribosome into a protein. So voila, look what happened. Now you have your own spike protein. So from this, you developed a spike protein, which is actually not even on the real virus. So when that happens, the body changes its mechanism. So now what happens is, here's your real spike protein that you're going to develop. That messenger RNA that is injected into your system changes into a process called translation. They make these spike proteins. These spike proteins are now in your system. What happens is then these antibodies start attacking these spike proteins. So what you've done is these spike proteins are a mimic. They mimic the real spike protein of a COVID. So once they do that, you develop a whole bunch of antibodies, right? So when the real virus hits your body, you've already have developed these antibodies to fight it. So what has happened, you didn't get injected by a new virus or a live virus or a particle of a virus. You got injected of a RNA that just makes these proteins that are part of the virus. And these proteins, now you have antibodies that inactivate these spike proteins. You don't have any attachment of the virus to your cell wall. You don't get sick. For safety, CDC also has something on their website called vSafe. You have the opportunity to call them, talk to them. And if you have symptoms, you can actually plug them in here. So there's also this type of systems available. Some of the side effects, very clear common side effects, are pain at the injection site. You get some fever, feeling tired, headache. That normally goes away within about 24 hours, 36 hours. These are mild, not much. And so, a good advantage is you are going to see this, but it's not going to last for too long. Rare side effects, again, there is some, but if you look at when we say rare, it's 1 in 10, 15 million. That is not uncommon. Those also occur in other vaccines. So it's something that is just vaccine-based. Risks, again, we're talking of the risks of getting vaccinated, very, very minor. There's a lot of people that talk about, they caused myocarditis, right? So look at vaccine-related, 150 cases per 100,000. If you get COVID, you get that vaccine, right? Much less. So even if you don't get vaccinated, your risk is so high. Same with death, right? COVID related, we've had 672,000. COVID vaccine related, much less. So you can look at that number. Again, when they talk about preteen, this vaccine does not affect anybody that's pregnant or anybody that's breastfeeding. There's a lot of clinical trials that have occurred that are on a very high frequency and has tested to be very successful. They've also used different demographics to make sure that the efficacy and the safety is equal in every type of a race, ethnicity, and age. As you see, we do not have a vaccine for 5 to 11 years of age right now because it's still on trial. It is now almost ready to be on the market, and they're hoping by, I think, Halloween, Thanksgiving, it is going to be ready. So again, these take that time. before and tested rigorously before they put on the market. Again, these are all the approvals, and again, more approvals are coming. And just, I think this morning, the FDA, Pfizer advised the FDA for approval for the 5 to 11. So again, it's a process, right? Okay, so let's look at where we are in looking at home in District of Columbia. So this is our vaccination rates. Remember the graph I was telling you, kind of pretty high during May, June of then kind of went down, and it's not going much up now. But if you look at it, our vaccination rate here in the district, 59% of individuals are fully vaccinated, 70.6 are fully and partially vaccinated. So we're getting up there, not as fast as we want, but we're still getting up there. That's a very important number. I'll get back to it, but I can just talk about it. This is the breakthrough vaccinations, and I'm going to go into more detail with that, with a slide that actually kind of shows that. So remember, I showed you the hospitalizations and the death numbers nationally. Look what we have in Washington, D.C. This is the number of deaths in Washington, D.C. from January to September 2020. It's a 2-week delay normally with our work because we try to clean the data, we analyze the data, we avoid deduplicate, we go through deduplication. So that's why it's that lag way. It is very clear when you look at the deaths, we've had only 9 vaccine related. Anybody that was fully vaccinated, there has been 9 deaths. People that were not fully vaccinated, 208. So look at the percentages. Individuals that were fully vaccinated, 4% of them passed, compared to 96% that were not vaccinated. Again, vaccines work, right? This is what the vaccine was manufactured for, making sure we decrease the death rate. This is very important. Again, this is to do with hospitalizations. Look at the number of individuals that were hospitalized from January to September. 5% only that were vaccinated. 95% of individuals that were not or partially vaccinated landed up in hospital. So again, very clear, it's avoiding people getting hospitalized. So now breakthrough infections, right? There was, I told you I was going to give you a slide on that. So let's look at it. What is a breakthrough case? Breakthrough case, the positive detection of a COVID-19 in an individual who is fully vaccinated. A breakthrough case expected as no vaccines are 100% effective, right? We know it. It's right here, right? None of them go to 100%. Close, but not. So we know when COVID-19 vaccine, Pfizer, Moderna, Johnson & Johnson, they said the effectiveness was around 90, 95%. Some were saying around 85. So think of it, even if you say an average of 90%, 10% of the population rare, but they're still going to get infected. That's a fact. That's a fact for any vaccine, right? So when you look at that, this is the most important slide when we talk of breakthrough. So what we have found, that number I told you, that 1.01, is the number of individuals in DC that have got breakthrough infections. Out of 424,000 that got vaccinated, 2,700 had a breakthrough, which is 1%. Now, remember I told you when these vaccines were actually, being manufactured, the efficient or the effectiveness was 90, 95%. So we expect 10% to actually maybe get, the disease, rare, but possible. We only have 1%. And this actually just a few weeks ago was less than 1. So it fluctuates within that 1, 1.1, 0.9. So again, that breakthrough is very rare. So that's why vaccines are working although you hear everybody talk about it being otherwise. This is a really good slide also, but just to kind of show you of the number of people that were fully vaccinated, uh, and the number, and so this is a great slide because this area here is kind of very clearly showing the summertime where there wasn't much activity. And there wasn't much activity because Delta was not predominant. Delta became predominant in the country around June the 28th. June the 28th is that magic number because that's the point when every positive, 50% or more of all positive cases in the nation were Delta. As soon as Delta hit, as you can see what happened. But look at what happened. Out of all the cases that tested positive, look how few, right, are fully vaccinated. So again, really very important to understand of where the vaccines are. This is also giving you an idea of how many were symptomatic and asymptomatic on individuals that were vaccinated. We are seeing many of them are symptomatic. So that's very important because that's a sign. If you're symptomatic, you most likely are going to be positive. If you're symptomatic, I don't know how much you guys know of these tests. So they call these antigen tests, PCR tests. The importance of an antigen test is if you're symptomatic, antigen tests are very, very accurate. If you're not symptomatic, then that so-called, it's called a pre-prevalence positivity goes down with this antigen, right? So if you're taking an antigen test, if you're symptomatic, especially if you're already vaccinated, it's going to tell you you're going to be positive. So that's kind of something to remember. So vaccines are there to end our pandemic. We know more vaccinated people, there's a fewer opportunity for that disease to spread. Another term for that, herd immunity, right? There's fewer opportunities for COVID to spread, which means there's fewer opportunities of new variants. So how are these new variants forming? People that are not vaccinated are actually incubators for these vaccines to mutate. They're almost like a petri dish. And that's why we are encouraging people to get vaccinated. We're still learning a lot about the vaccine, right? But what we know today is much more than what we knew a year ago. So when Alex and I started doing these, calls and getting these reopening plans implemented, we barely knew much compared to what we know now. That's why schools, universities are open because we now know how to mitigate this virus compared to a year ago. Then I just want to, I'm not going into this in detail, but just some terminology. If you guys don't understand it, it's just quarantine is, when you quarantine someone, you're a close contact that may have been in close proximity with someone that's positive, right? So that's why you quarantine the individual and you quarantine them because you wait for that incubation period. Incubation period for COVID, 5 to 7 days. It's normally 14, but you see signs and symptoms within 5 and 7. That's why we encourage people, if you were a close contact, don't test the next day like we start panicking. Because if you test the next day or 2 days after you were in touch with someone or close contact, you're going to get a false negative, right? Because even if you may have got infected, your body doesn't have the enough viral load for that test to pick that viral load up because this test may not be that sensitive. That's why we wait for that 5-day or at least 3-day for some circumstances where the body has enough viral load if you were really infected for the test to pick that up to make it a real positive and not a false, right? So that's kind of where those things come into play. Isolation is different. Isolation is when we know you infected, when you know you positive. So you isolate for 10 days. And then testing, again, this is again important. when to get tested, especially when you're traveling. Make sure you get tested because you want to make sure during your travel you were not in close contact or getting uh, asymptomatic where you could start infecting others. So let's talk about myths, right? And then I will almost then open it up to questions. Right. So mistreatment and mistrust. So a lot of people were talking about the Tuskegee study and all that, right? Those studies were unethical because there were no IRBs. After those studies, a lot of that came up. So these studies are valid, and to just make sure they went through a rigorous IRB process and so forth. So what happened in the past is people were doing studies without these IRBs, and so they took advantage of these patients. That does not happen again. If you guys are doing any studies at your universities, you will know an IRB needs to be applied for, approved before any study can be done. So, clear proof. Somebody says vaccines make you fertile. That's not true, right? Impotent. That's not true. There's also a lot of individuals that are talking about getting pregnant. You can get pregnant, vaccine's not going to do much. No breastfeeding, it's not going to hurt you there. I have a website right here where you can get all this information on the CDC website. Another myth that comes up, I already had COVID-19, so why should I get the vaccine? Well, remember that early slide I had? So even if you got COVID, you have, because of your natural immunity, you have antibodies. What the vaccine is doing is it's going to increase that antibodies. The more antibodies you have, the more immunity you have, the more safer you are, and the less chances of the COVID really getting you seriously sick. That's why even if you had COVID, get your vaccine. That's what it does. It just increases your immunity. Another one here, the vaccine can give you COVID. You know it's not going to do it now, right? It's not because it's not a live vaccine. It's a RNA, and an RNA is just a fragment, a synthesized fragment of the spike protein that's on the virus. So again, if someone says, I'm going to get COVID because of the vaccine, it's absolutely false. Some people are talking about my vaccine may change my DNA. Okay, so let's talk a little about this. I just want to make it very clear. Your mRNA is not able to enter the nucleus. So this is the nucleus of your cell, right? Where the mRNA goes is these areas, the ribosomes. These are the ribosomes, right? There's that. And once they attach to your ribosome, they get disintegrated because they form a protein. Once that protein forms, it's done. So nothing can ever go past these membranes because that's where your DNA is. So with that membrane, you have nothing to pass that. And the membranes are, these barriers. So it can't go through that membrane. So again, that's where your DNA is. So it can never integrate with your DNA because of that reason. So if someone says it's going to integrate with my DNA, it's just false. Then some people are saying the vaccines are causing variants, right? That's not true because look, when you're looking at the alpha, we identified alpha in September 2020, the beta in May 2020, the gamma in November 2020, the delta October 2020. Vaccines were not even developed that time, right? Were developed after that. So if they're saying variants, the vaccines are causing variants, no. The variants were already identified way before the vaccine actually came out because people started getting vaccines. I know we were the first, and my vaccine was December, so we know it was way after these variants came up. So more myths, right? Does the vaccine have a microchip? Absolutely not. Are they magnetic? No. I've already kind of said what an RNA is. An RNA is just nucleic acids, nucleotides put together to make a message, and that would give you the protein. Can you shed this to other people? No. Here's a good one. Does it affect other women's period? No. There's more resources right here for you guys. If there is anything you need to share, we also have great resources right here in our DC Health website. And this is how it looks. If you just go coronavirus DC vaccine information, you'd have a Q&A and you can go through it. Again, this is real. As you can see, this was just 3 weeks ago. Idaho hospitals are rationing because there's so many people that are going for COVID. 99% of them not vaccinated. As you can see in Alaska, same thing 3 weeks ago. There's a crisis of hospitals. Not a good sign. Get vaccinated. And this again, everybody 12 and older can get a vaccine in DC. And then hopefully by end of this year, it will be 5 and up. So we are really pushing for vaccines. And I'm going to end it then, open this up for questions. But I just just before I do that, what we are seeing right now is an increase in our cases regarding ages 5 to 11. So this vaccine is coming in time, because if we can decrease that, as you can see, our case rate is going down. Hopefully it continues to go down. So I'll stop on that, and then we can actually go for questions, and I'll be glad to answer those for you guys. So thanks,
Dr. Magna. Thank you so much. That was a lot of information. Wow. Before we go to Q&A, I just want to thank you again for the kind accolades at the start of your presentation, but I definitely want to acknowledge and recognize the other members of the Executive COVID Committee, namely Deborah Sullivan, our Vice President of Human Resources, Deputy Chief Ron Culmer, Dr. Mercy Ojumu and University Health Services, as well as Dr. Guillory, our Senior Vice President and Chief of Staff, and most recently, Leanne Hall, our Vice President of Communications. I'm probably leaving somebody off, and I apologize if I have. But Dr. Mangla, it seems to me you're telling us we're on our way down from the fourth peak, but I'm not hearing you say that we're out of this yet, right?
Absolutely.
We're not quite out of this.
Yeah, thank you for that, Alex. I deliberately have not said that because if I could project and postulate that, hey, this is going to happen, I'll be a millionaire today, right? I won't be in public health. Look at what the virus has done over this 15 months, right? It's gone up and down. Going down is a great sign. I don't even know what's going to happen in the next week, forget end of the year. And again, I'll tell you why. When you look at the trends, In the summer, people are gone. There's not much activity locally unless, people are visiting. Even last year, summer was kind of down. And then what happened is, as soon as we came to the holiday season, right? As soon as we came to the Halloween time, Thanksgiving time, Christmas, New Year, families get together. There's a lot of travel, and it just shot up. It spiked up. It's looking good now, and I hope it is. But we need to wait till that holiday season is over to really decide, okay, we're on the safe side. I'll be very honest with you. I was so optimistic. So was every other health official. When we saw that decrease, not just in DC, but nationally, earlier in the summer, and I'm going to just share that slide one more time. Right, if you saw this, when it came down here, we thought the fall was going to be safe, everything back to normal, there's no COVID, none of that, right? But you guys know it did not happen. And so I'm not saying we're going to be safe till I know more data, but I tell you what we can do to be safe. And I think I think UDC has hit the nail on the head with this. Continue with it.
So,
Yep, go ahead.
yeah, we have a question from one of our listeners who has asked, how has the vaccine worked with sickle cell patients, or maybe other types of patients with pre-existing conditions or disease?
Right. So they say it is, they have not, that's that is more a physician question overall. So depending on an individual, the physician may have more medical records to discuss those kind of scenarios. But overall, our suggestion, where CDC has made it very clear, if you have chronic diseases and if you are immunocompromised, then it's even more important to get the vaccine. As a matter of fact, if you're diabetic, if you are immunosuppressant, if you have blood diseases, if you have many of those, they are recommending that you may even need to get that booster. The importance of the booster, again, is, remember the slide I have, it's increasing your immunity. It's increasing your antibodies just to make sure that if you do get infected, your body can fight it very quickly.
Thank you. Doctor, after having COVID, how long can you test positive after
Yeah,
you've
so
recovered?
after having COVID, you most probably will test positive for 90 days. Excellent question. This is what happens in COVID. And so I'm giving you the reason behind it. When someone tests positive, the infectious period of that COVID is about 9 to 10 days. That's why someone isolates for 10 days. After 10 days, your virus starts disintegrating. Now remember, if you biology students, virus is not a live substance like bacteria, right? So it starts disintegrating, it disassembles. And when it starts disassembling, it starts shedding these particles, right? Now think of it, that sheds, in some people, the shedding could occur within weeks. Some people, it takes 3, 6 months. That's just our metabolism, right? So the reason you test positive is the tests that we use are PCR tests, or it's called an antigen, which is a protein test. When these viruses start shedding, they're already inactivated, they disintegrated, but they still have those DNA particles in them. So when your PCR test, when you do that test in the PCR, what happens is the PCR has these fragments, very distinct COVID fragments, and it's almost like a lock and key method, right? Antigen antibody reaction, similar to that. So when your test identifies that fragment, it does a positive test. But think of it, it may show positive, but you're not infectious because it's just a fragment. That's why you're going to test positive for that first 90 days, although you're not infectious. That's the explanation of why don't test 90 days or within 90 days of being positive, because you're going to get a positive and it's going to be a false positive.
Okay. So you covered this a little bit in your discussion of breakthrough, and I'm glad you went into that. But a question we have is, what are the possible actual causes of the fully vaccinated people who are testing positive for COVID-19 or getting COVID?
Well, there's a lot of reasons for that, right? Again, it's the Delta variant, as you saw that slide, is much, 5 times more contagious than the original strains. So number one. Number two, it really, is a matter of a person's immunity, right? Like I said, if you're immunocompromised, if you have, chronic disease, you want to make sure you have enough antibodies. And the third thing is, again, just the mitigation, right? So the more prepared, the more you wear a mask, the more you distance, your risk is less. So there may be individuals that are on a higher risk path. And when you're on a higher risk, you will get infected. Again, like we said, it's not 100% effective, so the chances are there. And so some people will get infected. And again, the
Great.
more, if you stratify by the individuals with breakthrough, and we're doing that analysis and looking at their almost, their health history, you see, were 80% of individuals that were breakthrough, where they had some underlying conditions, and that could be a possibility.
Thank you. I have a question from Francesca Alessi. I can't wait to hear your answer here. Let me read it. If there are two or more people in an office for an hour or so talking and wearing masks, could one remove their mask after the other person has left it on, or should one keep it on? And if yes, for how long? I thought the virus stayed in the air for several minutes, especially in non-ventilated areas.
Right. So that's an excellent question. Again, if you look at our guidance makes it very clear. You are, it's again, I don't know how many, if epidemiology or public health is taught at the university, but you are the definition of close contact is if you are less than 6 feet in distance, close to a person for 15 minutes or longer over 24-hour period. If you fulfill that criteria, you are close contact, and that means the possibility of you being infected is very, very high. So again, that is that clear definition that would answer your question. So when you talk of 2 hours, I wouldn't even think of anything else. I'm going to say you're close contact.
Thank you. Is there any data that cases in children 5 to 11-year-olds are driving cases in vaccinated persons?
That's a good point. So that also is a possibility. Again, whoever brought that question up, that is so important. That's why we actually asking people to get vaccinated, because at the moment, that is the population of high risk, right? They could get infected at any time and as fast as possible. So if they infected, they could introduce it to family members or anybody they close to because they are vulnerable. And so again, think of that close contact. The closer you are with individuals, the longer period you are with individuals, and depending on the mitigation of mask, distance, and so forth, you will eventually be regarded as being infected, right? So again, that is that risk population that we are very concerned about, because a lot of the transmission is going to come from that vulnerable population. So that's a great question. That's why we asking parents and everybody else, you guys get vaccinated, because if you don't, these are kids that are going to be in daycare centers. And if I show you some data that I have of daycare centers, I mean, it's shocking. And it's shocking because it's obvious they are not vaccinated. So again, that is a key population that could cause a lot of the transmission to others.
Doctor, I have another question about children, but I'll just quickly say I read what you mentioned earlier about the approval for 5 to 11-year-olds coming, or it's here, right? And so the next group will be the 6 months to 5-year-olds, right? And perhaps that'll be the group that'll be evaluated and approved by hopefully the end of this year, right?
Yes.
The next question is, if children under 12 years of age are not able to get the vaccine, okay, which not entirely accurate, but how are we protecting them by being vaccinated if we can still carry the virus and give it to the children? I would like more insight on the fact that it is a refusal to test vaccinated people when working in the child care field.
That's a long question. Let me try to break that up. Number one, that again, so that age is that high risk population. Once you're vaccinated, so this is the key. When you're vaccinated, what happens is when okay, let me move back. The virus is in your nasal and your pharyngeal cavities, right? That's why they do a nasal swab or they do a throat swab or a saliva test because it accumulates here, right? When you're not vaccinated, you have such a large viral load. That's why when you're talking, you sneezing, you're breathing, those vapors have those droplets, and you're gonna infect them. When you're vaccinated, what happens at that point is you still have that viral load, but that viral load, so vaccinated, you're protected. But if you're vaccinated and positive, you still have that viral load, right? Because you're positive. But that viral load disappears or decreases precipitously within 24 to 48 hours. So you don't have that large viral load. So that's again the importance of that vaccine, because even if you were vaccinated and positive, because of that low viral load, you're not going to infect the others as much as you would if you were not vaccinated.
Right. Thank you. Um, I have a comment and a question. Oh, well, let me back up here. We would like to encourage everyone to go to our chat before you leave this session today and answer the poll. There's a poll about how people feel about getting tested next week during our anticipated testing drive. We're thinking about and planning for testing next week for 2 days. That's going to be an initiative that will look at the rate of positive cases perhaps within our vaccinated community. We thought that was something that was brought up in previous town hall sessions, and so we set that arrangement, and we're planning to do that. We want people to go to the poll and please answer the question before they leave today about that. Um, so the next question is from Rebecca Bankhead. That was an amazing presentation. Thank you so much, Dr. Mangla. Are children in the District of Columbia losing their lives as a result of schools reopening? Are we aware of how many teachers have been infected since school started? Will children be vaccinated at school, or will parents be expected to get their own children vaccinated? That's a good question.
Great questions, and I have numbers for you, but I think if you go on our website, go to DC Health, and just look at that, look at school dashboard, right? On that school dashboard, we have it almost as it's user friendly, where you can articulate what number you want. So you can look at infections by teacher, by school, by date, and it'll give you a very clear indicator. Right now, 80% of all our cases are students, 10% are teachers, and about 9 point something percent are staff. So 20% of all the cases we've seen in schools, right? 20% are staff and teachers. Now, the students, think of it this way. It's so high because it's this particular group that we're trying to get vaccinated. So give it 6 months, those numbers are going to substantially decrease, right? And so all the data is available. And while you ask that question, I know this was an hour and it's just gone. But if there's something I have not answered for you guys, jot it down, let me know, and maybe we can do a session again in a month or two where we can discuss those kind of questions. But if I had time, I would go even in more detail. It's just we don't have time. But look at that website, and we have a dashboard that you can play with. It even has a number of outbreaks with different facilities, daycare, schools, universities. So it's pretty robust. Just have a look at it.
Thank you. Yeah, we are at our time, but I'm willing to go a little bit further if we can get some more of these questions addressed before you go, Dr. Mangla. Quickly, one that I can answer is, what is the university's plan for faculty that are not vaccinated? Well, the answer to that is that we have a vaccination requirement here at the university. If you do not get the vaccine, well, you can't come on campus. You can't do your job. You cannot come on campus. If someone has an approved exemption for medical or religious purposes, then those individuals are tested at least once each week, and we review the results of those tests, those COVID-19 tests. So that should be self-evident. Doctor, how long could antibodies last following vaccination?
That's a really good thing. So we're starting to see some sort of weaning after about looking at about between 8 and 9 months. They are still doing a lot of studies, and the studies, we would know from the studies, well, individuals may require a booster, another shot. That was initially the case. The immunization, the IPIC, which is the CDC's, advisory committee on immunizations, retracted that booster for everybody just, I think, 2-3 weeks ago, because they said at the moment it's plateaued, your antibodies has plateaued, and so it's pretty safe. But they have asked, like I said, people with immunocompromised, chronic diseases, and the seniors to really get that third booster, just because of their conditions, to make sure that they have that high antibodies available if they do get infected.
We are really getting some great questions here. Doctor, here's a question about the so-called long-term or long-haul COVID, right? So someone with a side effect from having COVID, like ear ringing, lingers after testing negative for almost a year. Can you talk to that?
Right, so there are some of these that are very rare. That is, again, a key question for your physician, because they need to understand your medical history, your conditions, and so, provide you more of a guidance on, what to take, what not to take. I mean, it's not a question I can answer because I don't know much of the medical history. So that may be happening. It's very rare. Some of these things are already entered in what's called the VAR system, which is a CDC system for adverse effects. Every time they get something like this, they're doing much more thorough investigations and trying to find the root cause about it.
Here's one I know that you can answer. Can air purifiers be helpful even if windows can't be opened, or especially if windows can't be opened?
Very helpful. I think I need to share some slide with you there. And I know I'm going to need to run for another meeting, but I think that is a very important question. And I do have a slide that I want to share with you guys, which kind of will clearly show, I'm going to find that slide, because I think that question, I want it to be justified by what I have. And so, I mean, that again, right, it's very clear that could be a complete another presentation. But if I look at, let's see. Give me 1 minute.
We'll go ahead and answer this question, Dr. Mangla.
Yeah, go ahead with the next. Yeah.
I think that, again, there's only a couple more. If there's any additional lingering questions that come in, I'll make sure they get over to you, and then we'll get a response back to the group, and we'll send it out. The question is, maybe I'll jump ahead. Flu shots are suggested every year during flu season. COVID has no season. COVID has no season. So are we talking about getting vaccinated every few months or getting vaccinated indefinitely?
We don't know. We don't have enough information on that. CDC is working on it. Right now, there's no talk about it. But while we're talking of flu, you could get, it is possible, and people are doing it. You could get, if you're not vaccinated with COVID, you could get them simultaneously. So that's fine. Yeah. So here's the slide. That was an excellent question. So if you look at this HEPA filters, so when you were talking of filters, this is a study that was done. And again, I'm not going to go into detail, but what they looked at is closed windows, open windows, windows closed and open with and without masks. What they show is if you have this filtering system, you can decrease the infectivity or the spread of COVID by 41-fold. Having said that, absolutely, these ventilators and these purifiers do work. It works, but the important thing there, the bottom line, you need a proper filter.
Okay. And that's something I think we would want to talk a little bit more about before we jump to making any decisions about our air filtration.
Yeah.
Looking at. So, Doctor, I understand that you have another meeting you have to go, but we do have some additional questions. I will forward them over to you, and then when you can, if you can provide responses, we'll get them back to the individuals who asked them. So thank you so much. This was an incredible presentation. We're getting a lot of thanks to you from our audience. It was very generous of you to share your time with us. I hope we can set up another a session like this in perhaps a month or in 6 weeks, or certainly before the end of the semester. And again, I want to thank everyone else who participated and listened in today. If anyone has any questions before I sign off, I'll put my email and contact information in the chat. Please get to me with anything that you'd like to us for us to follow up on. And that's it. We're over time. Everybody, thank you very much. We'll see you again in 2 weeks from today. All right. Have a great day.
Thank you very much.